दोस्तों, ये जो आपकी गर्दन का फ्रंट व्यू है ना, ये सिर्फ लड़कियों के नेकलेस या लड़कों की टाई दिखाने के लिए ही है। मेडिकल की भाषा में इसे कहते हैं एंटीरियर ट्रायंगल। इसकी बाउंड्रीज याद करना उतना ही आसान है जितना संडे को जल्दी उठना, यानी कि थोड़ा मुश्किल पर नामुमकिन नहीं। ऊपर आपकी मैंडिबल, जबड़े की हड्डी, जो तब बहुत चलती है जब सामने वाला फ्री का खाना ऑफर करे। बीच में नेक की मिड लाइन, वो लक्ष्मण रेखा जिसे पार करना मुश्किल है। पीछे हमारी प्यारी स्टर्नोक्लीडोमास्टोइड मसल, जो गर्दन घुमाकर क्रश को देखने में आपकी मदद करती है। इस छोटे से ट्रायंगल में भगवान ने इतना कुछ भर दिया है, कैरोटिड आर्टरी, मसल्स और नसों का पूरा जाल, कि अगर यहां से भी गलत टच हुआ तो सिस्टम हैंग हो सकते हैं। तो चलिए आज इस ट्रायंगल ऑफ मिस्ट्री का पर्दाफाश करते हैं।
The neck is a high-stakes bottleneck. It packs critical aerodigestive tracts, major vascular pipelines, and cranial nerves into a tight, highly mobile cylinder. Navigating this density requires a rigid map. Clinicians impose order on this anatomical chaos using a specific geometric framework known as the anterior triangle of the neck. This diagram illustrates the framework's boundaries. A sagittal line drops down the anterior median plane, from the chin to the suprasternal notch. The lateral border traces the sternocleidomastoid muscle's anterior edge, creating a deep V shape. Capping this is the inferior border of the mandible. Together, these three borders enclose the anterior triangle. This geometry is perfectly mirrored, providing paired, symmetrical triangles on both sides of the patient's neck. The superficial roof covering this space consists of skin, the superficial fascia containing the platysma muscle, and the investing layer of the deep cervical fascia. The deep floor contains the pharynx, larynx, thyroid gland, and the underlying musculature, all encased in visceral fascia. Defining this overarching perimeter allows a surgeon to establish their bearing before they isolate the millimeter-precise targets buried within. The macro triangle itself encompasses too much surface area for targeted navigation. To isolate specific structures, it is functionally partitioned into 4 smaller subdivisions. This source diagram demonstrates how intersecting musculature creates those partitions. The hyoid bone, the digastric muscle, and the omohyoid muscle act as the dividing lines, splitting the space into distinct colored zones. The first subdivision is the submental triangle, shown here in pink. It is a unique, unpaired median triangle situated directly beneath the chin. Its boundaries are formed laterally on each side by the anterior bellies of the right and left digastric muscles, and inferiorly by the body of the hyoid bone. The floor of this specific space is built by the right and left myohyoid muscles, meeting at the median raphe. Inside this pocket, small submental veins converge to form the anterior jugular vein. It also contains 2 to 4 submental lymph nodes, tasked with filtering lymph draining from the superficial tissues below the chin, the lower lip, and the tip of the tongue. Moving laterally, we locate the submandibular triangle, also referred to as the digastric triangle, highlighted in blue beneath the body of the mandible. Its superior boundary is the body of the mandible itself. The anterior and posterior bellies of the digastric muscle converge downwards to form its inferior apex. Superficial inspection of this area reveals the submandibular salivary gland, the facial vein, and the associated submandibular lymph nodes. Deeper within this compartment lie the facial artery and the submental artery. It is also crossed by critical cranial innervation, primarily the hypoglossal nerve and the mylohyoid nerve. By isolating these 2 upper triangles, clinicians establish a precise, predictable map for managing salivary gland pathologies and tracing lymphatic drainage originating from the oral cavity. Moving lower, we enter the most clinically critical subdivision of the neck, the carotid triangle. This space is a high-volume neurovascular highway. Returning to the diagram, the carotid triangle is marked in pale purple. It is bordered superiorly by the posterior belly of the digastric, inferiorly by the superior belly of the omohyoid, and posteriorly by the anterior border of the sternocleidomastoid. The chief arterial structure occupying this space is the common carotid artery. Precisely within the bounds of this triangle, the common carotid bifurcates. It splits into the internal carotid artery, which ascends to supply the brain, and the external carotid artery. Several major branches of the externocarotid arise right here, including the superior thyroid, lingual, and facial arteries. The primary venous structure sharing this tight corridor is the internal jugular vein, which collects drainage from the common facial, pharyngeal, and lingual veins. Running closely alongside these massive vessels is the vagus nerve, cranial nerve 10, along with its superior laryngeal branch. This diagram illustrates a highly specialized physiological structure located right at the arterial bifurcation, the carotid sinus. The carotid sinus operates as a baroreceptor. It measures blood pressure by detecting the physical stretch of the arterial wall, feeding this data directly to the brain via the glossopharyngeal nerve to regulate heart rate. Because the vessels in the carotid triangle are relatively superficial, applying external pressure here can artificially trigger those baroreceptors. In hypersensitive patients, this artificial signal causes a rapid decrease in blood pressure, severe underperfusion of the brain, and sudden syncope. The final, most inferior subdivision is the muscular triangle. It is a slight geometric anomaly, as it technically possesses 4 distinct boundaries. Looking at the yellow section of our map, we see it bounded medially by the anterior midline, superiorly by the hyoid bone, superolaterally by the superior belly of the omohyoid, and inferolaterally by the sternocleidomastoid. The chief contents of this space, which also form its floor, are the infrahyoid muscles, the sternohyoid, sternothyroid, thyrohyoid, and omohyoid. Protected directly beneath this muscular layer are the core tubes of the aerodigestive tract, the pharynx, the larynx, the trachea, and the esophagus. It also houses essential endocrine organs, specifically the thyroid and parathyroid glands. Notice that unlike the adjacent carotid triangle, the muscular triangle is largely devoid of massive neurovascular trunks. Its contents are primarily visceral. This specific geography provides a safer access corridor. It is the primary surgical route for performing thyroidectomies or establishing emergency airway management, like a tracheostomy. The submental, submandibular, carotid, and muscular triangles integrate into a single, continuous anatomical unit, the overarching anterior triangle. This framework allows clinicians to use palpable surface landmarks as a highly predictable coordinate system, locating deeply buried, invisible structures with extreme accuracy. The upper triangles dictate glandular and lymphatic assessment. The lateral triangle defines the zone of vascular intervention. The lower triangle outlines the safest path for visceral access. Mastering this geometry serves a functional purpose, transforming abstract lines into a surgical safety protocol. Without this topographical framework, any clinical intervention in the neck operates blindly, risking catastrophic damage to the tightest concentration of life-sustaining anatomy.
I do whatever it takes to pass this forever, no breaks. Anterior triangle, no Everest space. Anterior triangle, front of the stage, midline neck to mandible cage, sternocleidomastoid draws the line, 3 borders tight, yeah.